Good morning, good afternoon, and good evening. Welcome to Impacts of Protecting Life and Global Health Assistance Policy in the Trump administration. My name is Bergen Cooper. I am the Director of Policy Research at Change. I will be your moderator for this webinar. Change is a women's rights organization that advances gender equality by promoting the health and rights of women and girls around the world. We advocate for U.S. global health policies that are based in human rights and uphold the sexual and reproductive rights of women and girls. I'd like to thank our co-sponsors, who you will hear from later in the webinar, amfAR and the Global Health Justice and Governance Program at the Heilbrunn Department of Population and Family Health at the Columbia University Mailman School of Public Health. So before we get started, a bit of housekeeping. This webinar originally was recorded in June of 2020. There was a problem with the recording, so we re-recorded it, and that's what you are seeing today. So we were able to have live Q&A, and we replicated that for this recording today. So you will hear the same questions that everyone heard live. You will hear the same answers that everyone heard live. And just like everyone who was listening live, you of course have the opportunity to engage with our panelists. Everyone's email is available on their slides, and you are welcome and encouraged to reach out to our panelists if you have further questions after listening to this recording. Now, next slide, please. I am going to take a bit of the moderator's prerogative and tell you all a little bit about this policy and some of the research that's already been published that you won't be hearing about later in the webinar. So next slide, please. So what's in a name? You will hear so many different names to describe this policy today. Our speakers will be using all three of these names you see in front of you: Protecting Life and Global Health Assistance, the Global Gag Rule, the Expanded Mexico City Policy. At Change, we use the term Global Gag Rule. Our report, Prescribing Chaos in Global Health, this report maps the history, the trajectory, and the research on the Global Gag Rule. Now, as many of you know, the Global Gag Rule is a U.S. foreign policy that, when enacted, prohibits foreign non-governmental organizations that receive a certain category of U.S. foreign assistance, global health assistance, from providing, advocating for, counseling on, or referring for abortion services as a method of family planning, except in the cases of rape, incest, and life endangerment. In 2017, the Trump administration expanded for the first time the Global Gag Rule to include all of U.S. global health assistance. A second expansion in March 2019 prohibits any financial assistance by any recipient of U.S. global health assistance to any organization that engages in activities that are prohibited by the policy. This means foreign NGOs that receive U.S. global health assistance funds directly as a prime recipient or indirectly as a subrecipient may not grant any financial support, U.S. funds or otherwise, to any subgrantee that participates in activities that are banned by the policy. As such, the expanded GGR gags recipients, subrecipients, and donor projects that might not even receive U.S. funds. Next slide, please. So today you will be hearing about the impacts of the policy. Of course, we don't have time to cover every single impact that has been published, but I'd like to draw your attention to Change's Trump's Global Gag Rule data sheet, which is available on Change's new website, srhrforall.org. The data sheet covers some of the global impacts, including how the policy restricts SRHR information and comprehensive family planning and HIV and AIDS programming for pregnant women, adolescent girls and young women, women living with HIV, women in rural areas, orphans and vulnerable children, LGBTQI+ patients due to funding cuts and service delivery closures. It also covers the available data on how the policy weakens health systems and increases the risk of de-integration of some family planning and HIV services due to disruptions in funding streams, referral systems, and service delivery. Organizations report having to make the choice between continuing to provide comprehensive SRH information and services or to accept US funding, which restricts these services and programs. Next slide, please. I do want to share 2 change publications that document the impact of the policy. In Mozambique, the IPPF affiliate, Amodefa, closed 10 out of 20 of their youth-friendly clinics across the country, terminated 30% of its staff, and lost 500 community health workers who worked on HIV prevention as a result of Trump's Global Gag Rule. The policy has halted national progress for Malawi's national termination of pregnancy bill, which would allow for safe abortion services in select cases. Advocacy efforts related to the bill have been slowed by Trump's GGR due to the loss of partners who are unable to participate in the Coalition of Prevention of Unsafe Abortion in Malawi, COPUA, the primary coalition that leads Malawi's legal reform for safe abortion and developed the termination of pregnancy bill. These are just 2 sneak peeks of all the data that's available in these reports and of course on the data sheet. Next slide, please. So where's all this data coming from? Change and Columbia University's Mailman School of Public Health coordinate the Global Gag Rule Research Working Group. The group is an online and in-person platform for individuals to share questions and insights across our respective studies, provide technical support to each other's work, and coordinate countries and domains of research. You see here a map developed by Naomi Gaspard, who works with Emily Maistrellis at Columbia. You'll hear from Emily later in this webinar. And thank you, Naomi. This map covers the areas of the world in which the policy has been researched, and that research has in turn been published. So we know there's so much more research to come, and this map is going to come alive with colors in the next year and years to come. And this is really what we're here to talk about today. As you will hear today, we are too late in acting on some of the harmful and deadly impacts of the policy. The time to act was yesterday. Next slide, please. Again, my thanks to the team at Columbia who developed this slide based on the data that's available on Change's GGR data sheet. On the sheet, you'll see how this policy has impacted different areas of health, like WASH, HIV, maternal health, and many other outcomes. Next slide, please. Of course, there are many of our friends on the webinar today who have the data, who are going to tell you about it. But I want to acknowledge some of the additional organizations listed on the right who have also published data on the impact of this policy, on Trump's GGR policy specifically. Again, we know that there are many other organizations who are conducting this research, who have research underway and will be publishing in the future. Next slide, please. Now, let us move on to our next presenter. I would like to welcome the team from the U.S. Government Accountability Office. GAO is an independent, nonpartisan agency that works for Congress. Often called the Congressional Watchdog, GAO examines how taxpayer dollars are spent and provides Congress and federal agencies with objective, reliable information to help the government save money and work more efficiently. Let me hand it over to Leslie Holen, Howard Cott, and Kelsey Griffith. Leslie, handing it to you.
Thanks, Bergen. First of all, let me thank you again for inviting us to participate in this event. We are really pleased to be part of this effort on this important topic. We did this work at the request of a bipartisan and bicameral letter that came in. On the Senate side, we had Senators Shaheen, Blumenthal, Collins, Murkowski, and Murray asking us to do this work looking at the PLGHA, Protecting Life and Global Health Assistance Policy. And on the House side, we had House Foreign Affairs Committee Chairman Engel, as well as 5 other representatives that asked us to do the work. So there was a lot of congressional interest on this topic. This first review that we'll be speaking about today is a very data-driven review. It does not address the impact of it doesn't address the issue of impact on the ground of this policy. That was something we were hoping to do in a second job. This is just our very detailed data scrub. And before I turn it over to Kelsey and Howard, who really did all of the detailed work on this engagement, I would like to run us through our objective, scope, and methodology. So if we could go to the next slide, that would be great. Our objectives for this work were to look at all awards subject to the PLGHA policy, and also to look in detail at the awards involving NGOs that declined to accept the terms and conditions of the policy. The scope of our work was awards that were active from May 2017 when PLGHA went into effect, as well as all new awards that were made subsequent to May 2017, from then through September 30th of 2018. Our methodology was to have the agencies identify all affected awards for us, and we looked at obligations data that was available as of September 30th. And before Kelsey goes on into the next slide, I want to take just a few minutes to clarify our approach just a bit more. We asked 4 agencies, that was USAID, the Department of Health and Human Services, which was primarily CDC, but there were really 4 HHS components that were relevant for our work, the Department of State, and the Department of Defense, to include the Army as well as DoD's HIV/AIDS prevention program. We asked those 4 entities to self-identify all awards for us. We met with the agencies and had very detailed discussions about what data they could provide to us. Once we all agreed on the data that they would submit, GAO then sent a standardized data spreadsheet to all of the agencies for them to complete. We then analyzed the agency data to look for the number of affected and declined awards, total value of awards, the amount of award funding that was obligated and unobligated, implementing agencies, type of global health assistance, recipient countries, that type of thing. We analyzed the data several different ways. And for anyone who's not familiar, the term obligation, the meaning of that is the point where the US government enters into a commitment that then creates a legal liability for the payment of goods and services. So they're on the hook for the funding once an obligation is made. I want to explain just a little bit why we used a funding cutoff date of September of 2018. For all awards that were ongoing in May 2017, while funding that had not been obligated by that point when PLGHA was implemented, that funding was subject to PLGHA restrictions, agencies did not have available for us obligations or unobligated data as of that date. But they were able to readily identify obligations as of September 30th of 2018. So the GAO and the agencies, we all agreed to use this end date for our analysis. It's the end of the fiscal year, and it's the date when the agencies could most easily collect information for a time frame that we could analyze. And with that explanation, I'm going to turn it over to Kelsey to take over with the next slide. Kelsey, it's all yours.
Thanks. So this slide is going to give an overview of the universe of prime awards that were subject to the policy. As it shows, there are about 1,300 prime awards to which agencies applied the policy during our period of interest. As Leslie described, we used a snapshot of funding data that showed that these awards had about $12 billion in estimated planned funding that hadn't been obligated yet as of September 30th, 2018. So about 96% of that funding was provided by USAID and CDC, which is a component agency of Health and Human Services, in a fairly even split. By global health area, over 2/3 of this funding was for awards in Africa, and the top 10 locations associated with the most award funding were all in sub-Saharan Africa. And by area of assistance, over 2/3 of this funding supported HIV/AIDS assistance. The other third was for other global health areas. When I say over 2/3, that's about 8 of 12 billion. Next slide, please. This slide breaks down this approximately 12 billion by agency. I'll note that this is dollars and thousands. It includes, as you can see on the left, the agency, the number of awards, the estimated total value of the award. Note that some amount of that had been obligated before the policy went into effect and so would not have been subject to the policy, and then the estimated planned funding, not yet obligated by the end of September 2018. I'll just point out a few key facts on this slide. As we can see, USAID had 477 awards with the most total award value for both categories. And within HHS, I'll point out that CDC was responsible for almost all of this funding. Within the Department of Defense, most of this funding was associated with their HIV/AIDS prevention program. And finally, I'll draw your attention to Department of State, which had numerous awards, 402, but they were for a relatively smaller dollar value compared to other agencies. And this generally illustrates why we described the awards in terms of funding rather than just number. And next, my colleague Howard will discuss instances in which awardees declined to accept the provisions of the policy.
Okay, hi, this is Howard. We can move to the next slide. So this slide is essentially a summary of the information that follows. We asked the agencies to identify any instances in which NGOs declined funding due to the terms and conditions of the PLGHA. So we had to rely on the information they provided us. And I think we're pretty clear in our report throughout that this was all according to the agencies. These were the declined awards. And the universe of awards would only be those that were active in May 2017 when the policy was established. So it wouldn't apply to any new awards because you wouldn't be declining. Any award that comes in later, it would be to NGOs that have already accepted to accept the terms and conditions of the policy. So this applies to ongoing awards where the NGOs that were operating these programs, when new money became available for these ongoing projects, they had the choice to either accept the terms and conditions to continue on or decline to accept the terms and conditions, and then the program would come to an end, or a new provider would have to be found. So there were 7 prime awards where this happened, where the NGOs declined additional funding for their ongoing projects. And by prime, we mean that's a relationship between, or an agreement between the funding agency and the implementing partner. So we identified 7 instances. 6 of those 7 were USAID funded projects, and they left a total of $94 million unobligated when they declined to continue with the projects. There was 1 CDC award where the provider declined to continue, and that involved, they left $8.4 million unobligated, and that was a project in Ethiopia. There were 47 subprime awards, and by subprime we mean that's an agreement between the primary implementing partner and a sub partner that may be like a local clinic, let's say, that has a separate agreement with the prime award partner. So in those instances, there were 47 awards where the subprime NGO declined to accept the terms and conditions. And in those instances, the prime awardee would have to find a new implementing subpartner to carry on with the assistance, or they could deliver the assistance themselves, or in some cases, we were told that they might have delivered the assistance to a government agency, let's say a public clinic to deliver services. And so in those 47 subprime awards, there was $51 million left unobligated by those sub-awardees. The impact on services is something we don't know the answer to. So we can't say in any certainty that services were continued at the same level of quality and to the same targeted populations. We just don't know that. It's possible that a replacement clinic might have been found, but maybe they weren't able to deliver services to the exact same populations, or the same types of services. We just don't know. The other thing I want to point out on this slide, the last bullet, is that these awards, the prime and the subprime awards, involve a range of types of global health assistance. They were not just projects that provided family planning services. In some cases, it was HIV/AIDS or tuberculosis or maternal and child health. It cut across the range of global health assistance. Okay, we can move to the next slide. All right, so this is a table of just USAID's prime awardees. And the thing to point out here was AID did not identify the identities of all NGOs that declined assistance, and that's also true for the subprimes. But they did give us the names of 3 of the NGOs of these prime awardees, and that was because they had publicly, they were public about their declining of the terms and conditions of the PLGHA policy. And you'll see here that there were 2 awards, one for Marie Stopes International and one for International Planned Parenthood, that were over $70 million in total award value. And they left a lot of that funding unobligated when they had to decline the terms and conditions of the policy that were inconsistent with their missions. So Marie Stopes International declined about $50 million. And both the Marie Stopes and Planned Parenthood awards on this table were global projects, and they were primarily for family planning services, but they did include some assistance that was intended for HIV/AIDS assistance. We talked briefly with those 2 organizations, and they told us that they were able to find some other donors initially when they declined these funds, but not nearly to the extent that got up to the level of the funding they got from the U.S., which was their largest donor before this policy was implemented. So they were not able to continue the same level of services. They were not able to maintain the same level of funding because of the declining of this policy. Okay, we can move to the next slide. Okay, so this is a table of the subprime awards. That was the 47 subprime awards that I mentioned. These are all awards that were funded by USAID. I should mention that before I forget that that DoD and State Department, the awards that they funded, they didn't identify any instances in which awards were declined. So it was only AID primarily, and then the 1 CDC award. So these are the 47 subprimes that were declined. They left over $50 million unobligated out of a total award value of about $84 million collectively. And again, this table shows that the funding cut across different areas of global health assistance. See if I have any other notes about this slide. Yeah, I would just point out again, the prime awardees had to figure out had to find other local partners to implement assistance when these subprime NGOs declined. And AID did not give us like detailed information about what happened as a result of these declines, but in a general sense, they told us that in some cases when they had to find a secondary or a replacement partner, they might have had to spend some time doing some capacity building with this replacement partner, and that may or may not have led to delays in assistance. And again, this is the kind of information that we would have wanted to collect if we could do in-country work to find out in more detail about exactly what happens when partners have to be replaced. Okay, so that's all I have for this slide. We can go to the last slide. So these are 6 countries that had the largest amount of funding declined. This is out of the 47 sub-awards that were declined. So you can see that there was almost $10 million was declined by the sub-awardees in Senegal. And I wanted to point out that in this is an example where the services being provided did not include abortion-related services. Abortion is illegal in Senegal. So the local or the sub-awardee that provided services with this funding, that they were not involved in providing abortion-related services, but they declined because they were affiliates of Marie-Stopes International, and so all of the affiliates of Marie-Stopes International declined to participate once the PLGHA policy was established. The only other one I wanted to point out here, in Bangladesh, there were 5 different subawards involving declines by subawardees. And again, this was not just family planning. I think it included a tuberculosis case, a tuberculosis project, a project that involved integrated assistance, including nutrition services and maternal and child health. So again, this is another example where other types of assistance beyond family planning and reproductive health were affected by the PLGHA policy. And I think that's consistent with the findings of the study by amfAR and by Change about what happens when NGOs have to decline services. The same is true in Kenya. There was a large integrated project. By integrated, I mean it had multiple areas of global health assistance. So when the partner declined to participate, it wasn't just family planning services that came to an end, but so it was other areas as well, including maternal and child health. Okay, so that's our presentation, and I can stop there.
Great, thank you so much, Leslie, Howard, Kelsey, and thank you for that presentation. And I would like to now open it up to some questions that came in live during the webinar. The first question that came in is, do the State Department funds included in GAO's study include those from PRM as well?
Yeah, and I think this is Howard. The answer to that is no. The State Department projects that we identified were smaller ambassador grants primarily. And if you look at one of the earlier slides, you can see that there were a lot of state grants, but not as much money per award. So that was PRM funded projects were not part of our scope.
Thank you, Howard. And one more question that came in, which you did speak a bit about the primes who declined, but why could the 4 other primes who declined funding not be released?
Yeah, AID told us that was their policy, that they protected the identity of NGOs because of the sensitivity of the issue, and they only provided us the identities of those NGOs that were public in declining the funding associated with the policy.
Great, thank you for that clarification. And then finally, I want to ask you one last question that we're asking to all of our panelists today. I know you spoke a bit about original ideas around this research, but our final question is, if you had more time and ability, where would you like to take your further research on this policy?
I'll take that question, Bergen. This is Leslie. We really would like to, as we mentioned a few times during our presentation, be able to go in and look at the impact of this policy on the ground in selected locations. Our original plan was to take the data that we have analyzed and look at funding amounts or number or type of declinations, type of global health assistance, sort of look at where we ended up with all of the data and select then certain locations that look like they might produce some interesting results to go then do detailed work on the ground to really dig as deep as we can on the impact of the policy in these locations. COVID-19 has stopped us for the time being in being able to do this field work, but we are hopeful that in the future we might be able to take on such a review.
Thank you so much, Leslie. And thank you to your entire team, Leslie, Howard, and Kelsey. Thank you to David, who was able to join us live, but not today. Thank you all very much for your presentation, and thank you for joining us.
Thanks so much,
You're
Bergen.
welcome. Thank you.
We're happy to participate.
All right, everyone, let's move on to our next speaker. Dr. Giorgio received her PhD in public health from New York University. She is currently a senior research scientist at the Guttmacher Institute. Her research centers on sexual and reproductive health with a particular focus on measuring abortion incidence and safety, the impact of policy on health services and utilization, and socio-behavioral dynamics of HIV transmission. Maggie, let me hand it over to you.
Thanks so much, Bergen, and thank you for having me today. I'm going to be presenting results from a paper that we recently published in PLOS One. Elizabeth Sully is my co-PI on this work, and we also worked very closely with our partners Fred Mukumbi and Simon Kibera from Makerere University. This work is an investigation into the early impact of the Trump administration's Global Gag Rule on sexual and reproductive health service delivery in Uganda. This is typically the part of my presentation when I talk about the history of the policy and how it's changed under Trump, but Bergen did such an excellent job of that already that I can move on. Oh, next slide, please. And next slide again, thank you. So first I wanted to give some background into previous research on the GGR. The majority of this work has been qualitative in nature. There are a handful of studies that have tried to quantitatively assess the impact of the Bush-era GGR. And this work has suggested that there were reductions in rates of modern contraceptive use and increases in unintended pregnancy and abortion rates. However, this work largely compared rates across groups of countries. And only one study in Ghana tried to understand the impact of the policy in a more context-specific way. But we know that the policy's impact can vary dramatically based on the specific country environments where it is implemented. More recently, almost all of the research on the Trump administration's GGR has been qualitative and descriptive in nature. Much of that work has shown that the policy is having a negative effect on organizations, including disruptions in partnerships, confusion about the policy's implementation, and just an overall heavy administrative burden. And you will hear a much more detailed and interesting report on that work in a moment when we hear from our colleagues from PAI and Columbia. But today, the work I'm presenting is one of the first studies to attempt to quantitatively measure changes in service delivery as a result of the policy. Next slide, please. Before I explain the specific methods for this analysis, I thought I would explain the theory of change that we used to design our study and guide our analyses. After the GGR was enacted, organizations were forced to make a decision. Those that signed may have been forced to change the suite of services that they offered or end some of their partnerships. And organizations that chose to not sign the policy lost their US funding. And we hypothesized that in both of these scenarios, it could lead to a decrease in family planning service delivery. And this could lead to a decrease in modern family planning use, which could lead to an increase in unintended pregnancies, and ultimately lead to an increase in unplanned births and abortion. We split our study into two parts. Phase one is focused on the impact at the service delivery level, and those are the results that I'm presenting today. Phase two is focused on the outcomes at the individual level, and we're working on those analyses now. Unfortunately, we can't share those results today, but we're hoping to finalize those analyses and submit our paper for publication in July, and we should ideally have those results out by the end of 2020. Next slide, please. So now I'll talk to you a bit through the methodology of our study. Next slide, please. So to do this analysis, to answer this research question, we employed a quasi-experimental research design where we looked at changes over time from pre to post GGR implementation, and we compared facilities that were more or less exposed to the policy. And to do this, we utilized an existing ongoing survey in the field from the PMA 2020 data platform. This is run by Johns Hopkins University and researchers at Makerere University in Uganda. And it consists of an annual survey of women, as well as facilities that offer family planning services. And for this analysis, we were able to match health facilities that were interviewed in 2017 and then again in 2018, and we had a total of 263 facilities in our sample. In addition, we conducted original data collection by interviewing key informants at NGOs, the Ministry of Health, USAID, and other funders in order to collect data to create our exposure variable. Next slide, please. And what we learned was that in Uganda, 2 large non-US NGOs did not sign the policy and therefore lost their US funding. Since we did not have access to specific funding levels that were lost, we instead interviewed organizational staff to understand how the loss of US funding had impacted services and activities. And what we found was that a number of things did change, including a decrease in mobile outreach services, facility closures, some program discontinuation, and some staff reduction. And we classified districts based on whether or not one of these service changes happened within that district. And then we linked facilities to districts to classify facilities as being more or less exposed. And about half of our sample were in less exposed districts and half were in more exposed districts. And I'm using the terms more and less exposed to account for the difficulty in capturing all possible mechanisms for impacts on service delivery in Uganda, and as well as potentially countrywide effects that may have occurred. So we are not sure that any facility is truly unexposed. Next slide, please. We looked at changes in a number of key outcomes, including the provision of long-acting reversible contraceptives, contraceptive stockouts, mobile outreach visits, the availability of community health workers, the integration of HIV and PAC services with family planning services, and then finally, family planning quality of care. Next slide, please. For our, could you go back, I'm sorry, 2 slides. Thank you. We used multivariable and ANCOVA regression models in order to estimate the impact of the policy. I'm not going to talk through this model in a lot of detail. I just wanted to note that the key measure of the impact of the GGR is the estimated difference in difference over time and by exposure status that we get when we interact both time and exposure status in our model. Okay, next slide, please. So now to the results. First, I just wanted to note that when we looked at the characteristics of facilities at baseline, we found that there were no statistically significant differences by exposure status between our more and less exposed facilities. And that makes us more confident that our quasi-experimental design is mimicking a true experiment and that our results are, we can make a better causal claim when we talk through our results. Next slide, please. And what we found was that in the first year after implementation, there were not a lot of statistically significant changes in our measures of service delivery that we could attribute to the policy. We did not see a statistically significant reduction in whether facilities provided IUDs or implants, changes in whether facilities experienced recent stockouts of contraceptive methods, whether facilities had any engagement with community health workers or mobile outreach, and the integration of family planning with HIV or post-abortion care services. Next slide, please. What we did find was that there was a significant impact on the number of community health workers that were engaged by facilities. And what we found was that more exposed facilities experienced a reduction of approximately 3.8 community health workers after the GGR as compared to the less exposed facilities in our sample. Next slide, please. This reduction in community health workers who are working on family planning may ultimately reduce contraceptive use and increase unintended pregnancy rates in the affected communities. Community health workers are engaged by facilities to distribute short-term contraceptive methods as well as provide family planning education. And previous work has shown that community health workers are an effective way to increase access to modern family planning methods. And the work that we're engaging in now is looking at how these changes may have impacted contraceptive use by women in the affected communities. We did not see significant impacts on other outcomes, and there are several explanations for why this could be. Next slide, please. One was that we were limited in this study to only look at changes in outcomes that were previously measured in these PMA surveys. You know, if I could have, I would have, on the day that the policy went into effect, I would have gotten in a time machine, gone back in time, and designed the perfect baseline survey to look at changes in all sorts of different outcomes. But we couldn't do that. We were limited to what was already available. And what I would have added was not just looking at changes in whether or not a facility provided LARCs, but also changes in caseloads or numbers of clients served. Because it could be that these facilities are still offering these services, but the actual number of clients that they served decreased. We also couldn't measure advocacy around abortion, which is prohibited by the policy. And then finally, there could be countrywide chilling effects, where providers may misunderstand the scope of the policy and be less likely to engage in outreach activities or pursue partnerships with other organizations, or even provide certain kinds of sexual and reproductive health services, such as post-abortion care. And some of the qualitative reports have found evidence that this is likely going on, and we would have liked to have been able to measure this in our surveys. Next slide, please. We also think that there are a few mitigating factors that might explain why we didn't see larger changes in service delivery at this point in the study in the first year after the policy was implemented. First, I can't stress enough how resilient the organizations are who were affected. Organizations are being very creative and adaptive in finding ways to respond to the GGR in a way that minimizes the potential harm that could be felt by the women that they serve. Also, the role of stopgap funding is very important. As soon as the policy was announced, a number of other governments provided full or complete stopgap funding to several of the organizations who were impacted by the policy, and this has been essential for slowing the erosion of services. But thinking about this now in the context of the global pandemic, stopgap funding may be completely unsustainable given the current pandemic and the additional needs of donor funding. And the impact of the policy may increase in the long term, and I just want to stress that this is only an assessment of the early impact of the policy after the first year. Next slide, please. We have a number of policy recommendations based on this research. First, there should be sustained increased funding for family planning and safe abortion care that go beyond just stopgap solutions. There should be support for organizations and governments to become less reliant on single donors and to increase domestic funding. We should continue to promote SRHR policies that are grounded in sound evidence and not ideology. We should continue to push back on the expansion of the GGR. And that's the last one, I'm sorry. Next slide, please. And I just want to thank all of my colleagues and all of the other researchers who helped make this study possible, and I'd be happy to answer questions later. Thank you very much.
Thank you so much. What a dynamic presentation. And of course, we got questions in during our live presentation. So we're going to start with those questions. And the first one is, what did you use to measure the quality of care?
To measure quality of care, we used a previously validated measure that was developed by researchers at PMA that used about 130 individual indicators from the health facility survey. Unfortunately, we didn't have any indicators from the women's perspective themselves and the women's perception of their quality of care, which was one of the limitations of that measure, and our inability to find an impact on family planning quality of care may be because of that limitation.
Great, thank you so much. Another question that came in. Could the lesser impacts that were observed in Guttmacher's study be because the government is providing these services and the government is not impacted by the policy? Or is any other funding agency supporting these programs?
Well, that's an excellent point because the governments are exempt from these policies. But a lot of the work that the NGOs were doing in Uganda, who lost funding, were to support and provide technical assistance to public facilities, and so they were decreasing the gap of these kinds of services that were offered to women. And so the public-private partnership is so tight in these countries that, in particular in Uganda, that we don't think that that's a main reason for why we're not seeing impacts. And I'm sorry, Bergen, what was the second part of the question?
Oh, the second part was, or is any funding agency supporting these programs?
Yes, and I think that gets to the idea of stopgap funding and additional funds that have come in. In the case of Uganda, there was some funding that came in immediately after the policy, but certainly not a dollar-for-dollar match. And we don't think that played as large of a role in Uganda. We think it's more about a story about organizational resiliency, but it certainly probably played a role in our limited findings at this point.
Wonderful, thank you so much. And now for the final question, the same question that we're asking all panelists today. Thinking about where the policy is going and what data you already have, if you could continue your research, what would you like to look at next?
Ideally, I would like to continue the research in Uganda, but look at the longer term impacts of the policy. You know, what happens 5 years down the line when organizations have experienced this type of burden, and also depending on the outcome of the election, if the policy is rescinded, how quickly organizations recover and maybe are able to get back to a different level of service delivery. And we haven't seen an enormous impact in this first year, so you know, again, looking into the future to see the sort of longer term effects, and then obviously to look at the impact on women themselves and to see if there are changes in contraceptive use, pregnancy and abortion outcomes, which we're currently engaged in.
Well, all of that research is much needed. So I hope you get the opportunity to continue it, and we look forward to seeing the data as it rolls out throughout the rest of the year. Thank you so much for your presentation, and thank you for engaging with the question and answer part.
Thank you. It was wonderful being here.
And now let's hear from our next speaker. Jamie Vernaelde is a senior research and policy analyst at PAI, where she documents the impact of U.S. foreign policy on sexual and reproductive health and rights and barriers to access for vulnerable populations, with a focus on humanitarian settings. She has conducted research with civil society and produced case studies on the Trump administration's expanded global gag rule in 5 sub-Saharan African countries, as well as carried out other research to advocate for gender equity and rights-based development policies and practices. Jamie, I'm happy to hand it over to you.
Thank you, Bergen, for that kind introduction and for the overview of the policy, including all of its different names. Today, I'll be referring to it as the Global Gag Rule, or GGR, or inverted commas, the policy. For those of you who don't know us, PAI is an international NGO based in Washington, D.C. that promotes universal access to sexual and reproductive health and rights through research, advocacy, and strategic partnerships. A critical component of our DC policy-based work is that we have been documenting the Global Gag Rule in its current expanded iteration, as well as previous iterations under former Republican administrations in a series we've titled Access Denied. In this presentation today, though, I'm going to give an overview of what our research and activities related to this current GGR, the expanded under Trump, has looked like to date. Then I'm going to paint a broader picture of the biggest impact that PAI has observed. And from there, I'll briefly look at 2 recent documentation trips to Bangladesh and Burkina Faso. And I'll close out by quickly addressing what the loss of US leadership for SRHR and global health means at such a pivotal moment with COVID-19. So next slide, please. So as I mentioned, I'm going to speak to the qualitative evidence that we've collected so far. For the last 3.5 years, PAI has conducted 8 fact-finding trips to qualitatively document how the expanded GGR has rolled out in countries in both sub-Saharan Africa and Southeast Asia that receive US global health assistance. So far, we've published 5 of those case studies with more to come soon, fingers crossed. Our focus has been understanding the policy's impacts on US and foreign NGO operations, advocacy and programmatic activities, and where we could impacts to clients of SRH services. What we found is that the policy has impacts far beyond the NGO level to affect wider health systems, particularly as the policy interacts with other US foreign policy, the defunding of UNFPA, efforts by the administration to restrict global health funding, and the exportation of harmful rhetoric on gender and reproductive health broadly. This is all, of course, in the wider context of local government priorities and initiatives and activities of other donors outside of the US, and affects well beyond family planning and reproductive health programs. We've done these documentation trips at different points in time over the last few years, and that's important because it means that PAI has been able to see over time how the policy initially rolled out when organizations were freshly grappling with its implications through to just a few months ago in February. All that to say, our work has attempted to be representative of the situation on the ground and to capture what it means for the US government to sever partnerships with qualified and trusted NGOs as a result of this policy. And given the importance of those NGOs in service delivery and civil society advocacy, how those impacts to them can ricochet throughout a country's health system. Next slide. So I'm going to walk through really the biggest impact we've listed here. And there are more, but these are the ones I sort of want to stick to today. When we talk about communities losing access to contraception and services, it's about how the policy puts service further out of reach, particularly for really vulnerable groups, including rural communities, young people, and marginalized communities that rely on the private sector for the majority of their services. Some examples include how, with Marie Stopes International, for example, choosing not to comply with the GGR, their US-funded mobile outreach teams have suffered broadly. And some of those are operating in highly volatile zones, for example, in northern Burkina Faso, where there are very limited public health services, and where there and in other countries like Senegal, they provide things like cervical cancer screenings, STI treatments, in addition to family planning. Or like in Ethiopia, where those mobile outreach teams provide highly skilled services like permanent methods, and where the US was the only donor willing to fund those activities. In terms of contraceptives, another example is from IPPF member associations in Burkina Faso and Uganda, where they lost funds to distribute contraceptives in schools and to roll out injectable contraception for young people. So the end of these targeted programs that would have reached young people is really, really critical. In Nigeria, as a non-compliant foreign NGOs lose access to US funding as well as US donated contraceptives due to the Global Gag Rule, they have also had to scale back their services, which has this effect of pushing more clients to public sector facilities that then increases demand for commodities procured, by UNFPA, which places a strain on the agency, and that actually places a wider strain on contraceptive security for the country. So just those wider, larger systemic impacts. Moving on to breakdown of health advocacy and partnerships. NGO coalitions in Senegal and Uganda working to decrease maternal mortality due to unsafe abortion had to delay their programs and push things aside as member NGOs stopped engaging in the work out of fear of reprisals because they continued to accept US funding and compliance with the Global Gag Rule. This is even when the coalition work would decriminalize abortion and bring local law in line with the exemptions permitted in the GGR for life, rape, and incest. On operational burdens of compliance and non-compliance, those are often more difficult to demonstrate and to calculate, but we know that reprogramming of funding has impacts. Early on in the rollout of the policy, as I mentioned earlier, organizations were grappling with how to actually roll it out, how to ensure that their sub-grantees were compliant. And we just heard from time and time again, NGOs spending valuable time, staff, and energy on unanticipated overhead, seeking clarifications from their US funding sources, whether that was directly with USAID or a prime organization, and just all of that work and costs which detract from providing actual services to clients. One NGO in Uganda actually described 4 months of programmatic delays to comply. And that just means that the GAGR makes US investments less effective. Finally, on opportunity costs for NGOs and non-US donors, we see how just this policy snakes its way around the NGO and global health and development systems. The GGR unsettles future plans, it undermines local efforts to improve health outcomes, and it disrupts other non-US donors trying to work with the most qualified providers and organizations on the ground. Those organizations who are not complying, even if they get funding from other sources, the British or Canadian governments, whomever, have to reprogram funds. And we've heard in several countries with NGOs having to transition to actually humanitarian response to replace lost funding, and that means they've moved away from established service delivery work and populations who are reliant on their programs. There's also the wider issue that the loss of US aid is really major. Not all money is the same, not a dollar from the Canadian government is not the same as a dollar from the US government. That Ethiopia program that I mentioned earlier that provided permanent methods was praised because the US, like I mentioned, was the only donor willing to fund that type of project, and no one else was able to do it. And this, of course, is all even before we've even addressed the May 2019 expansion by Secretary of State Pompeo that will have outsized impacts on global health, particularly for non-US donors wanting to fund compliant NGOs. We don't have documentation on that yet, but we hope to have more of that in the future. Next slide, please. So as I mentioned, I'd just like to briefly touch upon a few aspects of our most recent documentation in Burkina Faso, which we did in September 2019 and Bangladesh in February earlier this year. With Burkina Faso, I've already mentioned a bit of some of the impacts to youth-friendly services, contraceptives, but we've also noted breakdowns in advocacy coalition work around safe abortion care among compliant and non-compliant organizations, the fear around the word abortion. But the major point I want to make is around the current humanitarian crisis actually in the country. Some of you may know that Burkina Faso has seen massive internal displacement due to conflict in its northern regions, much of the Sahel throughout that area as well. The takeaway I'd like you to have is that in Burkina Faso, the US had invested time and programming to bring family plannings and reproductive health service into its resilience program in those most affected regions of the country. Now, because of the GGR, the US is no longer funding those service providers who were working in those regions. And the 3 Marie Stopes Burkina mobile outreach teams covering 5 areas in those regions that were experiencing the most violence are no longer operational. They've been reprogrammed actually, as we mentioned, to other areas. And what's even more tragic is that the public sector services that are in that area have been really affected by the conflict and the health worker strike last year. The NGO that's picking up those US funds in those areas are not providing direct service delivery. They're actually supporting the government, and as I mentioned, public sector services have been massively disrupted. So that means that populations there really have no recourse for SRH service delivery. Additionally, those interaction of defunding of UNFPA and GGR means that as a response to this displacement, UNFPA and MSI were the 2 organizations really supporting the Ministry of Health to organize SRH services for those displaced populations. At the time, it was 800,000 people. And that just means that there's this perfect storm of existing fragile health systems, GGR impacts on qualified and trusted SRH service providers, and defunding of UNFPA. And again, that just demonstrates how US investments have become less effective, not only for expanding SRH access, but also increasing population resilience in a really, really vulnerable place. In Bangladesh, completely different situation, but again, want to touch on some of those humanitarian impacts that we've seen. Early safe abortion is actually legal in Bangladesh under something called amfAR, menstrual regulation, and their USAID actually funds NGOs to provide SRH services within public health facilities in partnership with local government actors. and that includes in the Rohingya refugee camps in Cox's Bazar. However, with the Global Gag Rule, those government facilities partnering with USAID can't provide comprehensive care, which should include menstrual regulation, that safe abortion care. While we've also heard examples very much in line with some of the impacts that I detailed above around the closure of clinics, disruption of contraceptive supplies, and coalition work, Bangladesh also provides a strong example of how the GGR impedes US government from funding and collaborating with the most affected and trusted organizations. As we've seen in other cases, subprimes who decline the Global Gag Rule are not just for family planning projects, and that's a really critical point. Foreign NGO that declined to sign the GGR was unable to bid for a nutrition project that would have reached all 64 regions in the country, including in some of the camps. The US Prime organization had to waste, again, as we've seen, time and resources to design an alternative since they couldn't cooperate and work with that most trusted provider. And what's happened is they're not going to be able to reach all 64 regions, and it's just, frankly, a bit of a mess instead. Finally, another critical point for Bangladesh, and this we saw throughout the country, is that compliance service providers broadly are reluctant to provide even post-abortion care. Again, as I mentioned, that fear of just the word abortion, even though post-abortion care can and should continue under the GGR. And that again applies to that situation in the humanitarian setting of Cox's Bazar, the world's largest refugee camp, where menstrual regulation isn't being provided based on the provider at the time due to GGR compliance concern. And so that means that, as Bangladesh is saying, a disaster within a disaster, as COVID is reaching the Rohingya refugee camps as well, the US will not be partnering with the most trusted providers, and vulnerable populations as a result will not have equal access to needed services. And where we see, especially in crowded refugee camps, there's concern for gender-based violence, pregnancy complications, and unsafe abortion. And we think that will result in compounding dangers for women and girls. Next slide, please. So to really briefly wrap up, one of the recurring themes that's come up as we've carried out this work is that the Trump-Pence administration has weakened the US as a leader and advocate for global health and SRHR. On top of the GGR and defunding of UNFPA, as we've heard, in addition to announcing plans for US withdrawal from and defunding of the WHO amidst this current crisis, for 4 consecutive years, this administration has proposed dramatic cuts to the US global health budget, targeting reductions in international family planning and reproductive health programs. While Congress once again thankfully ignored that proposed cut for fiscal year 2021, this administration has demanded once again for the UN to remove any references to reproductive health from its humanitarian response plan. And as we've seen with those examples above, how that's just going to have critical impacts for COVID-19 as these providers are cut out and not able to bid for US government funding, including UNFPA. And so I'll leave it there for now and just look forward to answering any questions.
Jamie, thank you so much. One of the questions that came in during our live broadcast was asking if you know what actions were taken by governments who were denied funding.
So to clarify, direct bilateral aid is exempt from the GGR. It doesn't, so that means that the GGR doesn't apply to funding from the US government to, say, a national Ministry of Health. However, given the support that certain NGOs provide to the Ministry of Health and that they are non-compliant, or as I mentioned earlier, UNFPA provides a lot of support in terms of contraceptive security and all of that work. That means that governments are going to be impacted indirectly through those partners. And what we've seen as well is that there's just governments with different levels of awareness of how GGR is impacting those partners and how that might affect their work and their priorities. In Ethiopia, that's actually a great example of where the Ministry of Health has been working really closely with USAID, as well as certain large organizations that have declined the GGR, and worked to make sure that services continue where they can and sort of reshuffling. But that does mean that governments on there, as we've mentioned, reprogramming, governments as well have had to understand that to help organizations sort of survive the GGR and continue vital work, they've have to shift their priorities as well.
Great, thank you. And let me close by asking you the same question that we're asking all of our panelists, which is, as this policy continues to exist and thinking about what the future of the policy might be, what are your hopes for future research?
My interest is very much in the humanitarian space, and just given, you know, as we're seeing more and more people on the move, more and more people displaced to urban centers, the rise of, you know, really massive camps and displacement centers, we're going to have to be looking at how the GGR, the defunding of UNFPA, and all of these overlapping harmful US policies are affecting some of the most vulnerable populations on the move.
Jamie, thank you so much. Thank you for your presentation today, your engagement with our question and answer, and thank you for sharing your information so that folks can get in touch with you directly if they have additional questions.
My pleasure.
And we look forward to hearing and seeing your research as it continues to unfold.
Thanks so much.
Jennifer Sherwood is a policy associate at amfAR, the Foundation for AIDS Research. In this role, she leads the development of amfAR's policy-related project portfolio in the areas of gender, women's health, and the sexual and reproductive health of key populations. Among her current projects, Jennifer is implementing a large-scale study to track the impacts of the US-Mexico City policy on HIV service organizations in 45 countries. Jennifer, I'm handing it off to you.
Great, thanks Bergen, and hi all. As mentioned, I'm Jennifer of amfAR, and today talking about amfAR's research on the effect of the expanded Mexico City policy on global HIV and AIDS programming. Can the next slide? Thank you. I think so. The first big bucket of work that we undertook in 2018 was a large-scale electronic survey in 45 different countries, which targeted all recipients of PEPFAR funding who were prime recipients. We spoke to country directors or program managers at these organizations and surveyed them on their knowledge of the policy, and if they did know that the policy was added to one of their grants or cooperative agreements, if they had changed anything of their operations in order to comply with the policy, and if so, what. So you can find our full policy brief online here, but I will just quickly go through some of our top line results from the next slide, which is that we got responses from about 45 countries, and of those organizations, at least one organization in 31 of those 45 countries said that they did alter their operations. These changes were created in sub-Saharan Africa, where the majority of PEPFAR funding is flowing, but were indeed global. And when I say changes in operations, I do mean that organizations were reporting reducing or stopping a service or an advocacy initiative. No one reported adding anything in relation to the policy, even though we did ask that. These changes did also congregate around reproductive health, but they were quite broad and did also include changes and reductions to HIV services, condom deliveries, cervical cancer screenings, and gender-based violence were some of the other big ones. The next slide. Thank you. The second big body of work that we undertook is examining how the policy is impacting global fund investments. We wanted to quantify the proportion of global fund funding that was subject to the policy globally, and to do that we manually matched a list of global fund recipients with those that were also co-recipients of US global health assistance. So we again have a ton more information in our policy brief online available here, but to walk through some of our top results, the next slide. You will find in our brief, firstly, a description of how this is happening, which can be from global fund funding flowing to an organization who also receives themselves US global health assistance, and that way global fund funding can be implicated by being a co-recipient with that funding, or secondly, through the Pompeo expansion, which was discussed earlier, that organizations who themselves do not receive U.S. global health assistance, but receive global fund funding from a prime that does receive U.S. global health assistance funding, can be restricted by the policy. So we and find overall that about 12% global fund funding could be subject to the policy. This is equal to over $1 billion. We break that down and look at which countries have the most global fund funding, which is restricted through these methods, and what countries have the highest proportion of their funding restricted through these methods. And importantly, also, we look at which type of global fund funding is also being restricted. We found that global funds investments in key population disease prevention was actually the most commonly restricted form of funding, which has been an important theme sort of throughout our research. The next slide. Great, thank you. So what's next for amfAR and for our research? The first major thing that we're going to be looking at this year is examining where PEPFAR may have missed targets or had large decreases in results for various services due to the loss of a qualified sub-partner because of the policy. This research initiative is actually inspired by a previous example that we found during our last round of research, which was in Eswatini. We found a sub-partner who was operating a standalone facility and was a major contributor to voluntary male medical circumcisions for the entire district. You can see their contribution here in the dark blue bars in 2015, 16, and 17. When that sub-partner lost funding and was no longer included in the VMMC program, in 2018, you'll see that the total number of circumcisions for the entire district decreased, and the PEPFAR missed its target for that entire district in 2018, and in 2019 the program has yet to recover despite increasing targets which have not resulted in increased results. We have found similar patterns like this in multiple other countries through our quantitative investigation of targets, and are going to be doing the qualitative work to verify this is happening and what the implications for the effectiveness of PEPFAR may be. The next slide. And secondly, and lastly, are the second big bucket of research that we are going to be undertaking is taking a similar methodology that we used to examine how the policy was impacting global fund funding, to examine how the policy may be impacting or is impacting other non-US and private donors. Indeed, the same mechanism through which the global fund money can be restricted by its relationship with US government funding can also equally be applied to private philanthropic funding, other non-US governments as well. And so we are working actively to see what proportions and sectors may be most subject to the policy through other non-government or non-US government funding streams. The next slide. So thank you. Those are our big projects, and we are. I'm looking forward to discussing more as they come out. So I'm happy to take your questions here or by email, which is on the screen. Thank you.
Thank you so much, Jennifer. And yes, thank you for sharing your information. I know folks are going to get in touch with you after this recording as well. We did have a question that came in, so I want to ask, could you speak a bit more about the impact of the policy on key populations and those subsectors specifically, such as men who have sex with men, transgender persons, and sex workers?
Sure, great. Yes, thank you. I think yeah, this has actually been a major theme throughout all of our research, and not something that we specifically set out to study with purpose, but had actually just risen to the top as a really important issue through everything that we've done. In the PEPFAR survey, we found that the organizations who were serving key populations, MSM, and sex workers were more likely to also report that they had altered an operation in relation to the policy. And this wasn't immediately clear to us as to why this might be, but anecdotally, we heard reports that the same organizations who provided sort of human rights-based care for key populations were also the ones that are more likely to be providing sort of comprehensive information and best practices around sexual and reproductive health, and so maybe reporting more changes. We also found that through our qualitative research that it was organizations reported more likely if they had to reduce services that they were going to reduce some of their outreach services or things that they considered more ancillary in order to maintain their funding to withhold their static clinic. And of course, outreach services and those services which are community driven do benefit populations who which are key populations, young populations, and so we saw this disproportionate cutback of services of those which did originally were designed to serve key populations. So those are some of our big things out of PEPFAR. And then just quickly out of Global Fund, our Global Fund research, as I mentioned, the Global Fund's key population funding was the funding that we saw was the most likely to be restricted by the EMCP. And this is really because we found that anytime you have area of funding and service delivery, like for PWID or like for MSM, you have fewer partners who are really able to provide really quality care for those populations. And so if you're in a country where there's just a few partners who are providing great PWID care, which are people who inject drugs, care, USG may already be funding all of those organizations. And so Global Fund, if they want to fund PWID work, are also going to fund those same organizations, and thereby really all the PWID work that's being done in that country is now subject to the gag rule. So I think just as a broad sense, just thinking about how this plays out, those countries which have specialized but smaller civil society groups and NGOs which are working on key population issues, if you're a private donor, if you're the Global Fund and you want to fund those, you're likely that your funding is going to be subject to the policy because there's just not as many partners doing that work.
Thank you so much. Thank you, Jennifer. And now I have to ask you the question that I'm asking all of our panelists. You spoke a little bit about what amfAR will be doing over the next year, but tell me your dream projects. Where do you want to go with this research? What would you love to be investigating in the future with this policy?
Yeah, thanks. I guess, I spoke a little bit about where we're heading next and some of our research initiatives that are on the immediate horizon. I think that those are going to be really important because I think they'll highlight where the policy may actually be making PEPFAR less effective of a funder, which is a huge issue, as an HIV organization, but also it's our largest pot of global health money, and is really important to make sure those dollars are doing are going to the things that are most effective. So I think that that's going to be a really important body of work that we'll undertake. And I think just additionally to one thing that I think is really important, which has come up, is that there's also in the policy something called the affirmative defense, which says that in situations where local law is sort of at odds with the policy and really does give clear guidance, the local law gives clear guidance that women have in full informed consent for reproductive health choices, including knowledge about termination of pregnancy or abortion, that law must be followed, and that it won't trigger a violation of the policy. And so I think that this is something that we are also interested in learning how that's being communicated and where that can be applied, and doing some more work to make that more public knowledge.
Thank you. That's great. I think some of what we've heard today is that that isn't as much of an area where there is public knowledge. So having more research come out there and having more attention there is going to be really quite exciting. Well, Jennifer, thank you so much for joining us today. Thank you for re-recording your presentation and to making yourself available to folks who have questions. And we look forward to hearing more about your research as it comes out.
Great. Thank you all so much. And thank you, Bergen. This was great.
All right, let's move on to our next speaker. Emily Maistrellis is a Senior Program Officer for the Global Health Justice and Governance Program at Columbia University's Mailman School of Public Health. She conducts mixed method, policy-oriented research on barriers to and facilitators of sexual and reproductive health and rights and justice in marginalized communities, and has worked in Sub-Saharan Africa, Asia, the Middle East, and the United States. Currently, Emily manages a multi-country study on the impact of the expanded Global Gag Rule on access to and provision of sexual and reproductive health services. Emily, thank you so much for being a co-host of this webinar, and let me hand it over to you.
Thanks, Bergen, and thank you off the bat to Change and to amfAR for co-sponsoring this webinar with the Global Health Justice and Governance Program at Columbia. I realize many of you might not know about global health justice and governance, so I'll just give a quick update for those who don't know. Global Health Justice and Governance is a program that's housed in the Population and Family Health Department at the Mailman School of Public Health at Columbia University. We're a program that integrates health, public health, legal, and scientific scholarship and practice from across the university at large on three main interrelated areas, which are gender justice, environmental justice, and food justice. And the Global Gag Rule work falls under the gender justice prong of that work. And as Bergen mentioned, for the last 2.5 years, almost 3 years now, we've been collaborating with research institutions in 3 countries, Kenya, Madagascar, and Nepal, to study the impacts of the expanded Global Gag Rule on sexual and reproductive health service provision and access. Our partners in this work are the African Population and Health Research Center, or APHRC, the Center for Research on Environment, Health, and Population Activities, or CRUPA, in Nepal, and l'Institut National de Santé Publique et Communautaire, or INSPC, in Madagascar. We're now nearing the end of this research, and today we'll be just sharing a sneak peek or preview of some of our top-line findings because the results are forthcoming. They have not yet been published. So I'm going to first just give you a little bit of information about what you can expect in the next couple of months from us in terms of publications. We're really pleased to be partnering with the journal Sexual and Reproductive Health Matters on a special issue that will house all of the findings from this work. And the title of the special issue is on the screen in front of you right now. In addition to the country-specific research papers from the 3 countries, the special issue will include a paper on the global governance of abortion, which draws upon a series of interviews that were led from New York, as well as several invited commentaries. The commentaries represent a range of disciplines. We're particularly excited about these commentaries because they're authored by legal experts, advocates, public health program implementers, many of whom are from the research countries. And rather than directly comment on the papers per se, many of these are contextual pieces that are written by those whose work is touched by the policy. So we're looking forward to putting together an issue that's really well-rounded and includes a lot of rich and interesting material and perspective that we hope a variety of audiences who are drawn to this work and the advocacy realm, the research realm, policy realm will want to engage with. So a couple of just last minute details about the special issue. It will be launched in the fall. We're thinking about October, and the papers will be published online as they're available before that. So in actually about 4 to 6 weeks, you should see the Kenya paper and the global governance paper available online. All papers will be open access. So please note this, jot it down, and we are looking forward to being able to share more details about the papers, but also present our findings in more detail at a later date as we get closer to the fall. Next slide, please. So what I'm going to highlight today, oh, actually, next slide. This is just a recap of the papers. So what I'm going to recap today or highlight today are findings from key informant interviews in Kenya, Nepal, and Madagascar. This is just a high-level summary of our methodology. And as you can see, we did interviews, as I mentioned on the previous slide, with global stakeholders as well as with key informants in each of the 3 research countries. So globally, we talked to donor and UN agency representatives who were based at headquarters offices, as well as international NGOs and representatives of international coalitions, also largely based in their headquarters offices, and who work across a variety of countries and topics related to sexual and reproductive health. At the country level, we did interviews with NGO and CSO representatives, public and private facility managers and service providers, government stakeholders, and clients who accessed safe abortion, post-abortion care, or contraception, depending on the legality of abortion in the country and the particular providers and clinics that we were doing interviews at. One thing to note, the public and private managers and service providers, as much as possible, we tried to link those individuals, or rather reach out to individuals within those facilities who were working on projects that were funded by some of the NGOs that were also in our sample from the NGO perspective. So we're really trying to triangulate our results across these categories and understand how the policy moves from the US overseas through contracts or subawards, and then moves through the health system, through the NGO communities into health facilities, to service providers, and ultimately clients. As you can see, we have a number of interviews. In Madagascar and Nepal, we did 2 phases of data collection, which is why the numbers are quite a bit higher. That was largely just trying to understand impact over a longer period of time. And also, as we entered each country, there were USAID funded family planning projects still ongoing that were in the final phases of wrapping up with some of the NGOs who had chosen not to certify the policy. So we wanted to do another phase of data collection to understand what was going on about, a year later, 8 months later in those countries. Next slide, please. I should note before we move any further, the Madagascar data is still being analyzed. So what I'll present here today from Madagascar is considered preliminary. But this is a snapshot, kind of a top-level snapshot across the 3 countries on our global interviews of some of our key findings. And overall, we see that the GGR has similar impacts in countries with varying abortion laws, dependence on USG funding support, geography, and civil society space. This was intentional on our part. We chose these 3 countries because of these differences that they offered us and the lens that we could then use to understand the Global Gag Rule in each and also across the 3. So some of these categories, I know that the print is quite small here: self-censorship, severed partnerships and missed opportunities, shutdowns of facilities and programs, and exacerbation of weaknesses in the public sector. And these are categories that others have found in their research, and we've heard about today in some of the other presentations as well. So on the one hand, it's really wonderful and interesting how those of us doing this research who are looking at the policy and impacts of the policy from slightly different angles, research questions or methodologies, are really starting to understand what a lot of the kind of expected categories of impact are. But at the same time, we're seeing nuance in how these categories of impact manifest in each of the 3 countries where we did research. And it sounds like colleagues from PAI and Change also noted that in their own research. So the papers that we're publishing in the special issue of Sexual and Reproductive Health Matters, and also what material I'm going to share with you next, really focuses on those nuances and trying to understand those kind of key differences and interesting differences and how some of these categories manifest. So next slide, we'll move on to the findings. So in Kenya, the GGR disrupts health system functioning by forcing NGOs to choose between funders and programs. And this is sort of a key finding or frame that we've written about in the Kenya paper. And NGO participants spoke to us on the ground about how organizations that do and do not certify the policy are experiencing financial and partnership losses because of these decisions, which in turn affects their sustainability and roles in the health system. So the first quote here is from a representative of a US-based organization that does not accept US government funding, who describes the untenable position that their subgrantees are in. And I'll just read this quote. It's either they accept to lose the funding from the US government or they accept to lose our funding. So for some, because we provide the majority of their funds, they have elected to lose the American, meaning US government, funding. That's not fair to them because it means they're not able to undertake the full scope of their activities. You can't survive on either or. They need both sources of funding, so it makes them very unsustainable. And this is an organization that works with NGOs and with the public sector to strengthen service delivery. And while they say in that quote that some subgrantees continue working with them, they've actually lost half of their community partners who had to certify the expanded GGR in order to maintain other sources of funding. And without those partners, activities like community health volunteer training, information campaigns, and service referrals were halted or reduced in some areas. And of course, the futures of all of their community partners were jeopardized due to lost funding streams. And something I forgot to note on the methodology slide, but was I think there in the text, is we did interviews with public and private sector facility managers and providers across multiple counties in Kenya. And in each of the countries, we also did we took a similar approach. We did interviews in the public and the private sector outside of capital cities. We did include capital cities, but we came to understand through this research how the policy really does sink in to the health system quite deeply through these partnerships, particularly with community-based organizations. Often it's the community-based organizations that are the bridge between the public and the private sector, or the NGO sector, doing things like referral from the community to the public sector. And when the GGR comes in and affects the relationships and the funding that those community-based organizations are able to get from NGOs, they're less able to work with the public sector in their own countries. So in addition, sort of on similar lines, our results indicate that in Kenya, choosing between sources of funding means choosing between implementing HIV or other SRH projects. PEPFAR is a very significant funder of HIV activities in Kenya. It's about 58%. And so organizations are sort of split into de facto groups. Certifying organizations implement HIV projects, and non-certifying organizations implement other SRH projects. And they're not able to work together. So the second quote here is from one such NGO that chose not to certify the expanded GGR. It used to work on comprehensive sexual and reproductive health activities, including abortion and HIV, but because it can no longer receive US government funding, it had to end HIV support specifically to 29 out of 30 facilities that it provided support to, and then effectively severed its relationship at large with those facilities. So that quote reads, HIV is being affected because previously we did a splendid job in the regions we were covering, and we've been able to reach out to many people either to test them, to offer ART, and other services linked to HIV care. But now we cannot get USG funding because we're being supported by a donor that funded family planning and abortion. Next slide, please. So of the 3 countries in this study, Nepal is the only one with an abortion law that's more liberal than the GGR, and a government that supports safe, free, legal, and accessible abortion services. And in the Nepal data, we're seeing that service delivery and referral networks are disrupted in 2 ways. One is through routine implementation of the policy, and the second is through overinterpretation of the policy. So providers at GGR certifying NGO facilities, that is facilities that are affiliated with or part of an organization that chose not to certify the policy, they are reporting that they're no longer referring women to non-certifying NGO facilities for any SRH service, as in contraception. And I'm sorry, I realized I just made a mistake about the facilities that are not doing the referring are those that have been affiliated or are connected to an NGO that has certified the policy. So they're overinterpreting the policy. They're not providing referrals anymore for women who are seeking contraception to facilities that may have chosen not to certify the GGR, but that offer contraception and that are a typical partner. So the policy really only restricts referral for abortion in those instances between those organizations. But these organizations are really pulling back the reins, and in some cases, as in this first quote, you see an organization that certified just removed the name of a non-certifying organization from its entire referral list. And it gave referrals in multiple areas. Contraception was the main referral area other than abortion that this other non-certifying NGO would have gotten referrals for, and they're severed now completely. Now, in the second quote, something kind of different is going on. Some providers of comprehensive SRH services at non-certifying NGO facilities report receiving fewer family planning clients. So that's sort of a consequence of the overinterpretation that I talked about before. But at the same time, there's something else going on regarding referrals for abortion, which obviously the policy restricts, but there's an exception built into the policy for abortion referrals if pregnant clients come in and tell their provider that they're seeking an abortion referral because they're pregnant, they know that they're pregnant, they've made this decision, and it's sort of full stop. It's all directed by the client. It's called a passive referral. So the client comes in, they know what they want, they're asking for an abortion referral. In that case, the policy does allow a provider to provide that abortion referral. But this is a gray area, and a number of interviewees from Nepal in certifying NGO facilities are hesitant. They described concern, and for many, they just stopped doing it because how can they know if USAID is going to come over, do a monitoring visit? How do they know that other NGOs are going to understand that they're still kind of in line with the policy? A number of interviewees really described this kind of concern about retaliation or potential, fear of funding being taken away from a prime partner by USAID. So this second quote is from a representative of a certifying NGO who, during their first phase interview, explained what passive referrals are to our interviewers. They knew exactly what the passive referral was, and they knew that they were allowed to do it. But here, this is a quote from their second phase interview. The participant states very clearly that they don't provide those passive referrals anymore because it's problematic to them. And there are numerous examples, too, to make this even more complicated, that make it clear that there is widespread confusion among providers and program managers from NGOs what the term passive referral means in the first place. We heard many definitions of passive referral that were not the correct definition. So that's it's murky territory for these NGOs and for these facilities, and you can see why they opt to sort of pull back rather than assert themselves in an area that they actually do have the ability to, given what the policy language is around passive referral. Next slide, please. Finally, in Madagascar, preliminary findings suggest that the expanded GGR exacerbates pre-existing problems in the family planning supply chain. Madagascar is one of the world's strictest abortion laws. It's inherited from French colonial law, and the penal code in Madagascar prohibits abortion without exception. It's punishable by imprisonment or by fine. And it is sometimes argued that the GGR won't have a significant impact in countries like this, where abortion is already prohibited. And we chose Madagascar quite deliberately in order to investigate the impact of the policy in this kind of context. Madagascar is also unique to the study in terms of its geography and significant rural population. There are many isolated, very hard to reach areas with poor roads, high fertility, and little government presence. So about half of all villages in Madagascar are located more than 10 kilometers away from basic health centers. And in addition, a quarter of the country's 3,600 basic health centers are disconnected from the official road network. So it's already quite challenging to ensure the timely delivery of medical supplies to basic health centers. So perhaps unsurprisingly, there have been many stockouts of family planning supplies in Madagascar. And most recently, there's been a significant stockout since 2017. And sometimes certain contraceptives that women use aren't available anywhere in the country. And these stockouts are caused by several factors. One would be certainly the defunding of UNFPA by the United States. Another would be the Global Gag Rule. A third would be pre-existing weaknesses, the road infrastructure, rural populations, supply chain, just locally. And the first quote here on the slide pulls out some of the new challenges in filling this family planning commodities gap that are related to the expanded GGR. So this quote reads, during the national quantification workshops of family planning work products for Madagascar, we present the gap in products which still need to be taken care of by donors. Each donor positions itself to take a certain % of the gap. When USAID no longer participated, there was a decrease in potential donors, and this has really had an impact on the availability of these products. So this needs a little bit of clarification. This interviewee stated that typically during national family planning workshops, organizations will discuss various family planning commodity needs and how to fill them. However, now that USAID has stepped back from funding some of the NGOs who come to those meetings, and that's what the interviewee meant by referring to USAID participation, the donor pool has decreased substantially, which increases the commodities gap and inhibits strategic planning at the government level, national level. So against this backdrop of stockouts, Madagascar has made several commitments and investments regarding family planning access and increasing it. In 2015, Madagascar committed to expanding contraceptive prevalence to 50%. However, in interviews, several NGO workers and regional public sector providers expressed frustration at not being able to meet client demand. And again, this is related to many factors, but one of them is GGR. So the final quote reads, "Furthermore, our rate of contraceptive coverage has decreased. The number of pregnancies at the facility has also increased. At the regional level, we have also noted that cases of abortion have increased." And when it comes to the cases of abortion increasing, just to clarify, some providers reported an increase in unwanted pregnancies, clandestine abortions, and PAC services in the public sector. And it's difficult to attribute this directly to the GGR, but it's very likely attributable to the family planning commodity stockout, which is caused in part by the GGR. Next slide. So this is just my thank you slide. I really appreciate the hard work of all of our partners at Columbia, ENSPC, CRIPA, and APHRC for gathering this data and pulling these slides together. Also to Sexual and Reproductive Health Matters for working with us on this journal, which we're very excited to release in the fall, and our donors. And thanks again to all for listening and joining us today.
Emily, thank you so much. It's so exciting to get a sneak peek of data, and we're very much looking forward to getting to dive into all of it when it is published in the fall. So I want to jump into some questions that came through during the live webinar. And our first question is about the passive referral, which you talked about a bit during your presentation, and a reminder for everyone that the passive referral is used in context in which abortion is legal. And so the passive referral needs to have 4 criteria met. A woman needs to come to a healthcare provider, and she needs to already be pregnant, clearly state that she has decided to have a legal abortion, ask where a safe and legal abortion can be obtained, and the provider believes that the ethics of the medical profession in that country require a response regarding where an abortion may be safely and legally obtained. So Emily, one of our colleagues asked if you could talk a little bit more about the passive referral and the various interpretations of it, which make using the option perhaps difficult within Nepal.
Sure. Thank you for the clarification too. I know I've kind of rushed through that description on the slide and got muddled a little for time. But yeah, the passive referral is particularly interesting, I think, in Nepal because of the liberal context legally for abortion. So in Nepal, abortion is legal through the first trimester and through about 18, if not now a little bit further along in pregnancy at certain exceptions. But public health sector is supposed to provide abortion free of charge to all women who ask for it. It's available on demand. So the fact that this passive referral is coming up as a problem really means there's a problem for the national public health sector as well, and the political and policy priorities of the government of Nepal. I think with regard to the confusion, we saw a lot of different interpretations around whether abortion didn't always even factor into what people thought a passive referral was. Sometimes it was about the mechanism for the referral, so like filling out a form for referral versus giving an oral referral, walking clients when we were talking about community health workers. Sometimes there's an accompaniment process for referral. So there were a couple of different ideas discussed when passive referral came up. We started asking quite specifically about passive referral because we were hearing from other participants similar information to what I presented on the slide, where someone clearly knew what passive referral was and then maybe walked it back or just told us they weren't doing it or something murky was going on there. And then when we started really asking about it, we got a lot of answers about what it was. So it's really hard. I think it's important to take that as a whole problem. You know, there's multiple prongs there, but it shows on the one hand a real still need for information. We did 2 phases of data collection in Nepal, like I said, and I think even in the second phase, we found that knowledge was quite poor. So that's one area for mitigation. Another would be, you know, up to civil society and government in Nepal and NGOs to really think about how they feel comfortable interpreting this gray area of the policy, and you know, how much does the government want to push their priorities when USAID is quite a big partner of theirs as well. It gets complicated, and very much is at the national it gets elevated to the national stage when we start talking about the legality of abortion in the liberal context in Nepal, which is again why I think it's really interesting.
Wonderful. Thank you so much. So another question that came in is, it is clear how the GGR impacts funding and service delivery, but could you say a bit more about how it impinges on national sovereignty for Nepal, the only country that noted this under the domains of impact? Is it solely due to the fact that Nepal's laws on abortion are less restrictive, or something else?
I don't think we could say that it's solely due to any one factor. I'm not going to say too much more, just because, again, we're putting the final touches on some of these papers. I can assure you that we will be talking about this issue in the Nepal paper. But I think it comes up as chilling effect in a couple of different categories. So this overinterpretation or hesitancy to muddy the waters with a prime partner or with USAID, and kind of intentional or unintentional consequences of that can be pulling back of policy priorities, or you know, USAID and the government partner on a lot of things, trainings, development of guidelines, just technical meetings, and those are all settings in which the GGR can kind of infiltrate, and if it can affect who gets invited, who used to get invited, what goes into those materials. And I think that's all gray area when it comes to sovereignty, and something that we're interested in, particularly when the presence of government and government priorities are part of the equation. But I don't think it's just about the liberal context. I think we and my colleagues would probably agree in other contexts where abortion is not as liberally available, legal, there still is quite a bit of sovereignty infringement coming through in different ways. I think we're all interested in exploring that, and maybe we can have another discussion about that at a future date.
Well, I love a cliffhanger response. Thank you for diving into that. And again, we look forward to seeing what the data show when it's published in the fall. So let me ask you my one final question that I'm asking to all of our presenters today, which is, where would you like to go with this research? Where would you hope to be able to continue and further your study as you look at how the policy exists or could exist in the future?
Sure. I think probably a lot of people say more time, being able to look at this in the long term, being able to understand impact even with a change of administration or even with a rollback of the policy. And I think that's absolutely valid, and we would agree with that. I think two areas that are really specific to what we've seen in our data from these 3 countries. One would be better understanding how the 2019 Pompeo expansion of the policy is really impacting, doing some qualitative research on that area. I think for Nepal and for Kenya, as Jennifer Sherwood mentioned in her presentation, those are 2 countries, if you look at the issue brief, that are potentially quite impacted. And in Nepal, at least, we were doing our second phase of data collection right after the Pompeo expansion was announced. And we know from our sample how many of those NGOs that we interviewed received Global Fund money. We would love to be able to continue this research to understand now, in another year later, have they been affected in a way that they weren't affected previously. Many of the responses that we got around GGR impact from those recipients in phases 1 and 2 was that they were not affected. They had not been asked to sign. But we did hear anecdotally, kind of after data collection had completed, this had changed for some of those partners. So being able to understand that would be quite significant. I think the same goes for Kenya, where the Global Fund obviously plays quite a significant role in funding for HIV. And the second area, I think, is more of a kind of policy, on the policy landscape level. I think something that we've learned in this webinar today and from the hard work of everyone in the GGR research working group is that we now have a really strong kind of woven together, really strong evidence base around GGR. And as much as possible, we've tried to really tease out impact on the ground that is connected to GGR. Attribution, though, is always difficult. And we've seen the Helms Amendment, you know, ever present also as part of what we pick up on the ground. And there's also the Hyde Amendment at home. There's the domestic gag rule at home. And I think a lesson from this research is really that we can strengthen the evidence base that we have around many US policies around sexual and reproductive health and rights. And if the interests were there from funders, I think we've all now kind of refined methodologies. We have a better understanding of how these policies work together in concert and also how they trickle into health systems, affect sovereignty, affect all sorts of issues. And I think we could produce a much stronger base that policy activists, policy makers could really use in the future.
Thank you so much, Emily. I couldn't agree more. There's so much more room to explore with the policy, and we have a very solid foundation, so continuing to build that base will be quite exciting. Thank you so much for your presentation. Thank you for co-sponsoring this webinar, and we look forward to seeing your research later this fall.
Thanks. So do we.
Thank you all for joining us. Thank you to our co-sponsors, amfAR and Columbia University. Thank you to all of our panelists, and thank you to you, everyone who listened live and everyone who's listening now on the recording. We look forward to engaging with you further, and if you have any questions, please reach out. Thank you once again.